Good evening everyone, welcome to Unacademy where you can crack NEET PG exams with us with all our top educators, quality content and have a great learning experience. So guys, let's crack NEET PG together. A little about me, I'm Dr. Sasha Menon Remedies. I have done my MBBS from Father Muller Medical College, Mangalore, my MD in Anesthesia from Father Muller Medical College, Mangalore. I have 2 publications and 1 paper presentation in the field of anesthesia, and I've been working and teaching in Bangalore for the past 2.5 years. So today's topic is central venous access and catheters. We just dealt with half of it half an hour back. For those of you who missed it, I will just run through what I dealt with briefly and then we will move on with the rest of the topic, which will be about insertion in the various sites. So a little about Unacademy. It's one of India's largest online learning platform where you get plus subscription and access to unlimited live and recorded courses from India's best educators. So what will you get out of Unacademy? Basically have our daily live classes. So we have our classes. So basically, when you go to a coaching institute, so when you are, when you have to travel, it's a lot of energy, a lot of time waste. Then once you reach there, your educator has to, basically, your educator. It's difficult for the educator to clear everyone's doubts. It's difficult for everyone to get the educator's attention. So with all that hassles, it is a little difficult to get yeah, so it gets a little difficult for everyone, right? But over here on Unacademy, you can chat with your educator, engage in discussions, clear your doubts and answer polls, and all this is while the class is going on. So you can engage in active discussions, clear your doubts, and all this while the class is going on. So the educator will clear your doubts during class or after class. These are all structured courses. They are all in line with your exam syllabus and help you best prepare for it. So the educators have researched and whatever is necessary and best for you all. Based on that, the syllabus is prepared. We have our live tests and quizzes. So we have our live tests and quizzes which will help you all evaluate your preparation. So we have regular mock tests, quizzes, etc., which will help you to evaluate your preparation. Then of course unlimited access. So one subscription gets you access to all the live and recorded courses, and you can watch from the comfort of any of your devices and from your home. So wherever you are sitting, whatever you are doing, from the comfort of your home, you all can watch. From the comfort of any of your devices, you all can watch. Then these are some of our top educators: Dr. Nikita Nanwani, Dr. Mohammad Azam, Dr. Preeti Sharma, Dr. Divish Mishra. These are the courses offered. So as you can see on the screen, there are various types of courses that are offered and the various subjects that you have to complete. These are not easy subjects. I know NEET PG is not an easy exam. There are so many subjects that you will have to complete in this small amount of time, and it is not exactly easy, I know, but it has to be done and we are here to help you all do this. And now various subjects like anesthesia, radiology, psychiatry, dermatology, you all didn't exactly have to go through them during your MBBS in detail, right? It was just there superficially. You all didn't have to go in depth into them. But over here, unfortunately, you all have to know a little more in detail than in MBBS. Not as much in depth. These subjects are very huge, but you all don't need to know that much in depth. So that's a good thing about it. So in the NEET PG, these are allotted around 11 marks each. But the good thing is you all don't have to go into detail into these subjects, right? When I say that, what I mean is, you all don't have to go into detail in the sense that you all don't have to, because so like in MBBS, you all just had a little bit. So even for the NEET PG point of view, the examiners do not go into depth to ask you all questions, right? But you all have to read these subjects. These are not questions that you all will be able to answer without going into the without knowing about the subject. Okay, so that's what I meant. These are not easy courses, so you have to go into the depth of the subject. Sorry. So yeah. Whereas your physiology, anatomy, pharmacology and all have 44 marks each, and they can ask you anything from any. These are some of the ongoing courses on our platform. So course on neurophysiology, GI surgery, cardiovascular thoracic surgery, course on pathology, respiratory system, larynx. These are all the various courses on our platform. Now coming to the subscription part, as you can see, there are various types of subscription on your screen. So these are the various types of subscriptions on your screen. So 1, 3, 6, 12, 24-month subscriptions, and you all can choose whichever one you all want. But for those of you who are taking the NEET PG this year, this should subsidize. Otherwise, the 12 and 24-month also are good subscriptions. I would recommend you all go for that. No harm in dropping a year. Nobody is going to ask you how long you all took to clear, etc. So there is no harm in taking your time and going through the subjects. Of course, like I said, these yeah, so it's more economical too, because after 6 months you all will have to subscribe again if you all need to refer to something else, see the classes again, take the test. It's a one-time subscription, whereas with the 12 months you have that buffer period, so as with the 24 months you have that buffer period. And like I said, it's this is something that you will be doing for a lifetime, so it is important that you all enjoy what you all do, right? So that's why it's very important that yeah, so like I said, it's important you all enjoy what you all do. So it is very important that you all uh, it is very important that when you all study for these various classes, you all will actually realize, some of you all will realize what you like and what you don't like. I'm saying it's for everyone, but most of you all, a lot of you all will realize what you like and don't like, and this will help you all make a decision. It is a career after all. You all will be doing it for the rest of your life. This is my code in red, SASHA. You can avail a 10% discount by using this code if you subscribe. So for the 12-month subscription, this is your 10% discount. The discounts are applicable on all these. This is your 24-month subscription. As you can see, the discount is applicable here to 10% if you use my code. 10% discounts. Now, today's topic was central venous catheter insertion. So, like we studied, the central venous catheter is basically it is an indwelling intravenous device that is inserted into a vein of central vasculature. The uses are, why is this inserted? So, anyone, and during insertion, always standard hygiene protocol has to be followed. Now, what are the uses of inserting this central venous catheter? Basically, for a difficult peripheral vascular access, patients with burns, previous vein injuries, IV drug use, volume loading. So, second use is for volume loading. Uh, so the flow rate is basically determined by, the flow rate within the catheter is determined by the Hagen-Poiseuille law, which states that the flow rate is directly proportional. So the Hagen-Poiseuille law, this is just for those of you all who missed it, the Hagen-Poiseuille law states that the flow rate is directly proportional to the pressure difference. This is not important, but it is directly proportional to the radius to the fourth bar of the catheter and inversely proportional to the viscosity of the fluid. This is the viscosity and the length of the catheter. So this is a more direct relationship, the radius of the catheter and the flow rate. So as the radius of the catheter increases, the flow rate will increase. So shorter, that is because as the length increases, the flow will decrease. So a shorter and greater caliber catheter will deliver greater volume over equivalent period of time. Then if any caustic medication has to be provided, the central access is always better. So vasoactive medications like vasopressors or inotropes, irritant substances like the chemotherapeutic agents, cytotoxic drugs, high concentration solutions, total parenteral nutrition, all are delivered through the central line. So central venous pressure monitoring. The central venous pressure monitoring is a pressure that is measured in the central veins close to the right atrium. It indicates the mean right atrial pressure and is frequently used as an estimate of right ventricular preload. It is used as a guide for fluid management, though some researches suggest otherwise. So repeated blood sampling. So introduction of pacemakers or pulmonary artery catheters for hemodialysis, hemoinfiltration. These are the various uses. Now contraindications, absolute contraindication will be overlying skin or soft tissue infections, thrombophlebitis are absolute contraindications. Relative contraindications are distorted anatomy, any trauma, deformity, burns, infection at the site of the access like cellulitis, uncooperative patient, any proximal vascular injury proximal to where you are inserting, bleeding disorders, anticoagulation or thrombolytic therapy. Now with this bleeding disorders and anticoagulation, as generally ultrasound guidance is recommended. It is a 3% complication rate as long as there is no arterial puncture. So as long as there is no arterial puncture, it's just safe. And bleeding disorders are an absolute contraindication for subclavian access. So subclavian access should not be attempted with bleeding disorders. So types of central venous catheters: non-tunneled, tunneled, peripherally inserted, implantable ports, single lumen and multi-lumen catheters, and each lumen must be treated as a separate catheter. Now these multi-lumen catheters, basically they're available. The advantage is you can have 2 or 3 infusions with these catheters. Multi-lumen, this is a triple lumen, this is a double lumen, this is a single lumen. So you can have multiple infusions with one venous access, and this is generally a 7 French. The triple lumen, yeah, so the catheter sizes are basically in French. Catheter sizes are measured in French and gauge. Okay, French is what is used for central line insertions. So basically 5 French means 5 into 0.33 for conversion to mm, right? So 0.33 is the conversion to mm. So 5 French, what we generally use is a 7 French, but this is basically how the conversion goes. So it increases from 0 in increments of 0.33 millimeters. That is your French. The gauge is basically expression of how many wires can be placed side by side in a given amount of space. It varies inversely, gauge and varies inversely with diameter of the catheter. So basically when I say it varies inversely, the greater the gauge, the lesser, so the lesser the gauge, so like a 16 gauge cannula will have a greater diameter, right? So it varies inversely, the gauge varies inversely with the diameter. Now your 18 gauge will have a lesser diameter than the 16 gauge. So this multi-lumen catheter is basically triple lumen, which is a 7 French catheter, and it has an outside diameter of 2.3 mm, and that is 7 French, and it houses one 16 gauge and two 18 gauge channels. Now open-ended, the catheter is open at the distal tip, and the catheter requires clamping before entry into the system. Clamps are usually built into the catheter and requires periodic flushing. So these are the blue things here are the clamps that are built into the catheter, and this is from where the flush has to be given. So types of central venous catheters: closed-ended, a valve is present at the tip of the catheter or at the hub of the catheter. Clamping is not required as the valve is closed except during infusion or aspiration. So the types of central venous catheters: silicone catheter is basically used for the longer duration catheter. So if the catheter is, they are more expensive, and if it is known that the catheter will be kept like for maybe for a month or so, it is preferable to use the silicone catheters. Polyurethane are generally shorter duration, like when the catheter will be kept for a days to weeks. Now coatings, they can be antimicrobial or antiseptic coating. There are two types of antimicrobial coating available right now. That is your chlorhexidine plus silver sulfadiazine, plus silver sulfadiazine, and the other is your minocycline and rifampicin. So minocycline and your rifampicin. Now this chlorhexidine plus sulfadiazine, minocycline and rifampicin. So your chlorhexidine plus sulfadiazine is the antimicrobial action is for 2 weeks, whereas with the minocycline and rifampicin, the antimicrobial action is up to 4 weeks. So this is preferred to the chlorhexidine sulfadiazine, minocycline and rifampicin coating. Now heparin coated, basically the problem with heparin coated is sometimes what happens is when a thrombus can form at the tip of the catheter, which is inside the lumen of the vein. Now when this thrombus forms, bacteria can come and bind to the thrombus and it can lead to sepsis. So to prevent this, there were heparin coated catheters. Now what was the problem with these heparin coated catheters was, the two problems were, one was heparin gets washed away quickly. Gets washed away, and the other was heparin induced thrombocytopenia hit. So the thing is the risk benefit ratio. So as soon as heparin is given, it gets these coated catheters are put the heparin over the coating of heparin gets washed away. So when you weigh this advantage for that short-lived advantage over the tendency of heparin induced thrombocytopenia which can occur, if this is more dangerous, as a result it is not generally called for. Then radioepi to confirm the placement of the tip, generally barium or tungsten is used. So the type of CVC inserted depends on the therapy to be administered, the length of therapy, so short term or long term, so that will depend on the type of CVC, silicone or polyurethane, the type of therapy, whether it is for what do you call it, whether it is for chemotherapy or for it is for vasopressor administration, or it is for just for long-term antibiotic administration. Then previous, if there was any previous device located, any inserted any complications with it. So these basically this chemotherapy, the dialysis patients and all, they would have had these central lines inserted previously. So you need to ask them whether there was any complication, and of course the type depends on the patient preference, where the patient wants it, etc. Non-tunnel catheters. So this is the polyurethane catheter, single or multi-lumen. The flow varies depending on the size and the internal diameter. It is inserted percutaneously. The internal jugular vein, subclavian vein, femoral vein is inserted. Advantages are easier placement and removal. Advantage economical. Disadvantages are high risk of infections, unused ports, must be routinely flushed with heparin solutions, clamp, gets dislodged more easily, etc. Now coming to the insertion, this is where we stopped. Now Peripherally inserted catheters, so peripherally inserted central catheters, they basically, these are known as PICC lines. Anyways, I'll come to that at the end of the class. For now, we'll deal with the central lines. Uh, Now, what is the problem with the peripheral catheter that is inserted, into the small veins on the hand? So these are basically 18 to 22 gauge catheters, and they are 5 centimeters. They are short and they have to be replaced every 3 to 4 days. So a new vein has to be punctured every 3 to 4 days to limit the risk of phlebitis. Okay. The arms for peripheral catheter insertions are preferred over the legs because of the higher incidence of venous thromboembolism. So, cannulation of the peripheral veins is best suited for a short-term venous access, like in the emergency department or during a short operative procedure. For actual volume resuscitation, the catheter is too short, right? So central vein is preferred. For most ICU patients who are critically ill or require prolonged venous access, cannulation of large veins is the central veins is more important. Then for ICU patients who are stable, uh, who are chronically stable and require prolonged infusion therapy, a peripherally inserted central line is also good. We'll come to the peripherally inserted central line later. Now for insertion, basically the Seldinger technique is used. So informed consent has to be obtained from the patient. It is a sterile technique. Adequate skin preparation. So adequate skin preparation with the sterile sponges and betadine solutions, spirit solution. Sterile equipment, so setup of equipment, positioning and identifying the landmarks, adequate local analgesia to relieve the pain during the first injection has to be given. The person performing the procedure also has to be sterile, right? So sterile gown, sterile mask, sterile gloves have to be used. So your Seldinger technique is basically a modified Seldinger technique. So the vascular access is obtained with this 20 gauge needle which is attached to the syringe. So as you enter the skin, once the vein is entered, there will be backflow in this syringe. This syringe will be disconnected from this needle, and this guide wire is passed through the needle which is left inside the vein. The guide wire is passed fully in till a 20 mark, which will be a 4. So on the guide wire, on the catheter, there will be this 4 mark which indicates 20 centimeter. So once it is inside, this needle is withdrawn over the guide wire and taken out. Then a dilator is taken and the dilator is passed over the guide wire and pushed in through the skin incision to dilate the vein. The dilator again is removed over the guide wire, and then this catheter, triple lumen catheter or single lumen or double lumen, is passed over the guide wire. One of these ports has to be opened. The guide wire will come out through this port. It is very important to catch the guide wire. The guide wire, there are chances of the guide wire getting lost. It is a hazard. It must not be permitted. The guide wire is held steady. The catheter is threaded over the guide wire. Once the entire, up till this blue mark is inside the skin, the guide wire is pulled out and the catheter is sutured after confirming backflow in all 3 ports. So coming to your internal jugular vein access. So the cannulation of the internal jugular vein was popularized because of the assumption that this procedure, which is performed at the base of the neck, so it is performed at the base of the neck, should eliminate pneumothorax. Okay, that is why it was popularized. However, this is not the case. Pneumothorax is a major complication of it's almost the same following cannulation of the internal jugular vein and the subclavian vein. So with the subclavian vein, there was more chance of pneumothorax. So this method was popularized, saying that there is less chance of pneumothorax with this method, but this is not true. So So aside from mistakes from the anesthesiologist side or the intensivist side, the cupula of the lung can protrude into the base of the neck as because of high tidal volume. So when the patient is on ventilator, because of the high tidal volumes, that the tip of the cupula of the lung can protrude at the base of the neck and during mechanical ventilation, and this can lead to pneumothorax. So basically the anatomy of the internal jugular vein. So the anatomy is the internal jugular vein is located under the sternocleidomastoid. So this is your sternocleidomastoid. So it is located under sternocleidomastoid. First point to be remembered. Just a sec, guys. So it is located under the sternocleidomastoid and runs obliquely down the neck on a line from the pinna of the ear to the sternoclavicular joint. So it runs obliquely from pinna of the ear to sternoclavicular joint. Right, so it runs obliquely from the pinna of the ear to the sternoclavicular joint. Turning the head to the opposite side will straighten the course of the vein. So that is why the head is turned. As you can see, the head is turned. So turning head to opposite side straightens course of the